I'm Emma Baker. I'm currently the Clinical Vice President of the British Pharmacological Society. I'm a Professor of Clinical Pharmacology in London at St George's, and I'm also the Training Programme Director for Clinical Pharmacology in London. So my job today is to talk about tackling polypharmacy. And in preparing for this talk, I reflected on my career as a consultant in clinical pharmacology. And in April 2019, for the very first time, I will be paid for doing clinical pharmacology in the NHS. I've been a clinical pharmacologist for 18 years, and in that time I've mostly done respiratory medicine. So what I'm hoping is that we can now grab these opportunities that Munir has laid out before us, and that for you will be paid to do clinical pharmacology and not just acute medicine or hypertension or whatever else it is, and that one of the ways we can do that is by really growing our specialty and having our own bit that we do that nobody else, well, other people can do in collaboration word, but that we have our unique thing. And so today we're going to tackle, if you like, looking at complex prescribing and a complex prescribing service, and have some great help from many of the registrars who've started to do this in London. But my job is to sort of set the scene and talk about how we might tackle polypharmacy. So I'm going to briefly outline the problems and opportunities, although Munir's done that beautifully for me. I'm going to just describe what currently happens in the ways of medicines reviews. I'm going to introduce a few resources to you that you could use in your own practice. And then I'm going to look at a practical approach that we've been taking at St George's and others are doing elsewhere in London. And then also think about strategy, how we can get this more widely across the NHS and grow more jobs. So, as Munir's beautifully put, polypharmacy is the concurrent use of multiple medication items by one individual. And I like to say it's the new epidemic. There's over 1 million people now taking 8 or more medicines, and a third of people over the age of 75 take 6 or more medicines, and a stat I heard just yesterday was that now it's half of people over 75 take 5 or more medicines. So it's incredibly widespread, much more common than ischemic heart disease. On the right there, you can see how medicines use has changed since the inception of the NHS in 1948. We don't have any item dispensing data from then, but you can see that the total NHS drug costs was 31.7 million. Of course, inflation has intervened. But between 1988, when I qualified, and the current day, the number of items dispensed in the community has trebled. Now it's 1.2 billion a year. Every person in the UK, on average, is currently prescribed 20 prescriptions a year. And the total NHS drugs cost is now into many billions of pounds. So it's a growing epidemic, and it's an opportunity for us. Many of you will be familiar with the King's Fund report, and I think before we go on to talk about how dreadful it is that people are on so many drugs, first of all, we should celebrate that they're on so many drugs. Again, at the inception of the NHS, the average life expectancy was 65 years. Now, if I make it to 65, my life expectancy is 91, so that's quite cool, so I hope I make it to 65. And a lot of that is down to development of new medicines. So, for example, before antihypertensives, malignant hypertension had prognosis worse than cancer. And now people can have a normal life expectancy with medicines. Heart failure, cancer, many different conditions where medicines have made a major difference to survival and quality of life. So before we start dissing medicines, we should celebrate them first. And appropriate polypharmacy is for an individual who has complex or multiple conditions is where medicine's use is optimised and according to best evidence, which may not always be there for multiple use of drugs. But the King's Fund define inappropriate polypharmacy as where multiple medicines are prescribed inappropriately or where the intended benefit of the medication is not realised. And being on lots of drugs increases your chances of not getting the right medicines as much as it does increase your chances of medicines-related harm. So what is the definition of polypharmacy? When I started thinking about polypharmacy, I think it was 5 or more medicines, but the number keeps going up as that becomes more normal. And so the threshold could now perhaps be considered 8, 10, 15, 20, and I'll show you the polypharmacy prescribing comparisons in a minute. We could use the King Fund definition and define polypharmacy by appropriateness. And you've heard already that there are many tools that can say whether drugs should or shouldn't be used. The Beers criteria of potentially inappropriate medicines, various other mnemonics about which drugs maybe shouldn't be given to a patient. Or we could perhaps define polypharmacy by the risk of harm. You will hear in a minute a bit more about the anticholinergic burden. Drugs can have that and cause confusion and falls, and that can be cumulative if you're on lots of drugs. Patients on multiple anticoagulants are at increased risk of harm, as similarly with multiple drugs likely to cause kidney injury. So the definition of polypharmacy can be a bit tricky, but probably includes all of these. These are the polypharmacy prescribing comparators, and these were developed by something called the Academic Health Sciences Network in Wessex. And the idea of these is that they can then use these to create a dashboard, particularly useful in primary care, to look at look in your practice or in your region, what's the average number of unique medicines per patient, what is the percentage of patients who are prescribed medicines over these threshold values, 8, 10, 15 or 20, patients with a high anticholinergic burden score who are on multiple anticoagulant or antiplatelet medicines or on more medicines, multiple medicines that can cause kidney injury. And these are useful, perhaps not at an individual level, but they're useful for practices to see how they're doing compared to other practices. There may be many factors. For example, if you have an elderly population, you'll be maybe more likely to have a polypharmic population. But also they can be used to identify patients who perhaps might benefit from seeing a clinical pharmacologist. So we should use these to our advantage. So a little bit about the harms of polypharmacy. In this slide, I've tried to summarize some of the ways in which polypharmacy can reduce the benefits from medicine. People who have multiple conditions are less likely to be on evidence-based treatment, and this is one example on the very left of the slide. Here we've got a study from Hart in 2015 that looked at people after a myocardial infarction who had COPD. There were just about 6,000 of those. Who didn't have COPD, 94,000 of those. And you can see that the odds ratio after a myocardial infarction of being discharged on a beta blocker if you had COPD was 0.26 compared to people without COPD, so 74% less likely. And you might say, well, everybody's afraid of giving patients with COPD beta blockers because of the risk of airflow obstruction, and I should hasten to add that that is an unfounded fear, and people with COPD are more likely to die of their heart disease than they are of their COPD and should be on a beta blocker. However, you can also see that they were also less likely to receive an ACE inhibitor or an angiotensin receptor blocker, aspirin, a statin. And so they're less likely to get evidence-based treatment for their cardiac disease. If you're on lots of drugs, potentially your drug interactions may reduce treatment benefit. And here's just one study from Japanese patients who underwent percutaneous coronary intervention who were on the antiplatelet ticlopidine, and those who had a proton pump inhibitor as part of their therapy had an increased probability of having a major adverse coronary event compared to those who weren't on a proton pump inhibitor. On the right, I've put the law of diminishing returns. And this basically shows a list of drugs that each cause a relative risk reduction of a second coronary event in the 2 years after a coronary event of around 25%. And you can see that on none of those drugs, the baseline 2-year event rate is 8%. Now, each of them causes the same relative risk reduction, but when you add them, the absolute benefit decreases. So if you add aspirin, the absolute risk reduction is 2%. Then you add the second drug, 1.5%. The third drug, just under 1.5%. And the fourth drug, you're only having an absolute risk reduction of 0.7%. And so perhaps you could argue that the most important thing to do is to make sure the patient is taking the first 2 drugs It's of course we want to get them fully optimized on evidence-based treatment, but if we want to put our energy into something, is to get them on some treatment and then perhaps to build up the other treatments. So there are a whole range of reasons why patients with polypharmacy may get less benefit from their drugs. I find it quite striking that for every one drug you add to somebody's treatment, you increase the risk of everything by about 15%. So you increase the risk of adverse drug reactions by 13% for every additional drug. And of course, 2/3 of adverse drug reactions are preventable. You increase the odds of a medication error by 16%. And we know that there are an estimated 237 million prescribing errors in the UK every year. And they cause around 712 deaths and contribute to 1,708 deaths a year. So we don't want errors and adverse drug reactions. And the more drugs you give somebody, the less likely they are to take them. So for every additional drug, the odds of poor adherence increase by 14%. And you can see here that over 50% of patients, I think it must be more than that, don't take medicines as intended. And the wastage costs the NHS 300 million a year, which could certainly employ those extra 72 clinical pharmacologists, or however many it was. In our work, and I'm going to introduce Chris and James to you in a minute, but in our work at St George's, we've been looking at the clinical practice research data link. And I think one of the things that really struck me is polypharmacy is not just cross-sectional. We think of a patient on 8 or more, 10 or more medicines. That's at that time point when we see them. But polypharmacy is for life, not just for Christmas. Here's a patient who was 61 in 1997, and he was then registered with his GP, and so he appears on a big data set called the Clinical Practice Research Data Link. And what we've done is plot his medicines from when he was 61 to when he was 81, with the time on the x-axis and the number of drugs on the y-axis. And you can see that he wasn't taking anything in 1997. The green line shows the number of individual prescriptions he receives every year for individual different drug. And the red line at the bottom shows the repeat prescription. So you can see that he's not only getting an increasing number of regular medicines, but he's also getting lots of short courses. The purple line shows his lifetime exposure in the number of different pharmacological agents he's prescribed. So his statin, his beta blocker, every time he's prescribed something, he gets a ka-ching, another drug. And you can see that this poor man has got over 80 drugs. And in 100 patients with polypharmacy, I think the average lifetime exposure over 20 years is about 45 drugs. So they get prescribed a lot of drugs over a longitudinal period. And as he gets older, you can see the blue line shows the number of prescriptions he requires. So this poor guy is never away from his GP. If you look at the natural history of polypharmacy as well, you can start to see what the medicines are for. And this is the same patient now with his drugs plotted at the year in which he was first exposed to them. And you can see that back in 1997, he started an antihypertensive, and so preventative drugs are in blue. Dark blue. He then had multiple short courses of treatment for things like antibiotics and pain relief and creams. And in 2002, he seems to have had MRSA eradication. And then, so they're shown in green. He then starts to get on drugs that are more long-term, so repeat prescriptions for symptoms, like antihistamines and pain relief and inhalers. And as he then develops his long-term conditions, he gets on more drugs for disease control, for depression and prostatism and heart failure. And then finally, at the end, you can see the red drugs are the prescribing cascade. And what's happened here is in this patient actually had prostate cancer and irradiation, which led to proctitis. So he's on a lot of drugs to try and stop the proctitis. But the prescribing cascade are medicines to treat iatrogenic issues. So you can start to classify the medicines. And then we can look at how that relates to the life stages and what does polypharmacy look like longitudinally. And here I've now plotted the life stages on the x-axis and represented the different types of drugs in colours. And you can see that accumulating from health, where hopefully most of you are now, where you maybe occasionally have a course of something for I don't know, paracetamol by the time you get out of here from your headache, to then your first long-term condition. I'm getting to the sort of age where I'm expected to accumulate a few, and you may be then starting to be on preventative drugs or your first drug for long-term disease control. And then as you develop your multimorbidity, you may be getting on multiple drugs for primary and secondary prevention to prevent something in the future, as well as to keep your diseases under control. And as you accumulate drugs, you get side effects, and then you maybe end up on your gastroprotection and your bone protection and your prescribing cascade to protect you from the harms of the drugs that you're on to protect you from something else. And at the end of the life event, I've put Vocodflex, which I think is the world's most unmemorable mnemonic, curiously memorable for all of that. And it was coined by a geriatrician in Israel I'll introduce you to later, called Garfinkel. And this is where patients become very old, comorbid, demented, frail, with limited life expectancy. And at this point, perhaps treatment priorities change, and I've reflected that by stopping some of the medicines for prevention and disease control, which then allow you to stop some of the prescribing cascade. But not everything just has to automatically be crossed off. I just want to point out that polypharmacy is caused by prescribers. And if we look on this slide on the left, I've got my poster boy for polypharmacy with his prescriptions in red and now his GP visits in blue. And particularly the top blue line is the number of visits he makes to his GP. And in this case, obviously, if you have to have a prescription, you might have contact with your GP, but it's a bit of an iterative process. So when you see your GP, you get another prescription. More concrete evidence, if you like, is on the right from some patients in our hospital. We had 120 COPD patients admitted with an exacerbation over a 3-month period, and we followed them for a year to see what happened. And these patients accumulated, on average, 1.3 new drugs in a year, so their polypharmacy increased. And you can see that the number of new prescriptions was correlated, after adjustment for age, gender, and baseline comorbidities, with the number of times they came into our hospital, with the number of times they came to A&E, and even with the number of outpatient visits. On the right, you can see it wasn't because they accumulated new diagnoses, it's because they accumulated new drugs. Again, back to the point, is a lot of this polypharmacy may be appropriate, but prescribers cause polypharmacy. So to tackle polypharmacy, we now know that it's a longitudinal. So it's not just about taking a patient on 20 medicines and stopping some of them. It's about thinking about a whole population approach. And as clinical pharmacologists, we're not very big, so we have to try and influence everybody rather than do it all ourselves. And so I've plotted polypharmacy perhaps as we might plot cardiovascular disease here. And thinking about it from primary prevention, in the loosest sense of inappropriate polypharmacy, of course, from not being on any drugs through to secondary and tertiary prevention as you increase the number of medicines, and perhaps treatment. And it's a bit of it's a concept rather than absolute. So don't come back to me and say, well, over 10 medicines isn't treated. And of course, we should always be encouraging alternatives to medicine, education, lifestyle, social support, counselling. I always say to my patients, if you had a small child, you'd take them to the park, get them fresh air, run them around, give them organic pureed vegetables, wouldn't let them drink and smoke, and you send them to bed early. So that actually is the key to good health, but none of us would die of boredom if we did that all the time. And so there's obviously a compromise. So perhaps then what do we do about the drugs? Whenever we're prescribing short courses, we do need to make sure we have a clear stop date so people don't get stuck on drugs forever. I'm not advocating that we must always stop a drug, one in, one out, when you're on a few drugs. But every time you prescribe for patients with a few drugs, you should still be thinking, is there anything that could stop? Once you're getting into the 5 to 10 meds, then we're up to medicines reviews and deprescribing. And then once we're getting into multiple medicines, then we're going to need maybe more than one person to sort this out, multidisciplinary approach. And we may need onward referral to a complex prescribing clinic. So there is our opportunity to provide policy and leadership for the whole workforce, education for the more difficult cases, and specialist practice for the hardest patients. And we're going to talk about that more today. So medication reviews, what's currently happening out there? And this is from the NICE guidance. All the slides will be available to you after the meeting, so you'll be able to look up the references if you want to. And you can see that there are different levels of a medication review. So level 0 might just be a patient going into a pharmacy and asking a question about their drug. Level 2 might be a prescription review. So you might be looking at some of the patient's prescriptions, see whether the patient's using the drugs. Level 2 is called a concordance and compliance review, usually perhaps looking at medicines for a particular condition. Here it says such as asthma. And I guess we're starting to be down at level 3, a clinical medication review, a full structured medication review with the patient's full notes, ideally with the patient present, usually reviewing all medicines prescribed and maybe with a single health professional or a multidisciplinary team. You can see that medicines reviews mean a lot of different things to a lot of different people. And that is the problem with the evidence behind their use, which I'll introduce you to in a few minutes. And there are lots of people in this space trying to tell us how to do it well, or tell everybody how to do it well. So here's a few references again. It will come out, and I've got the links to these things, but this is from something called the NICE Key Therapeutic Topics. And the NICE Key Therapeutic Topics are not guidance, they're a collection of evidence and a collection of information. And so it's quite a useful little secret backwater on the NICE website if you can find it. And this points to resources from the Specialist Pharmacy Service, Scotland and Wales, who are always ahead of England on this, the King's Fund, the Royal Pharmaceutical Society, GPs, and Prescrip is a very useful set of resources around medicines optimisation run by pharmacy. There are a few sites, so deprescribing.org is a Canadian website, which is sadly disappointing in that actually it has evidence-based guideline for deprescribing 3 drugs, but it's those 3, it's very useful. And Azara in the front row has pointed out the Polypharmacy app to me, which is an app of NHS Scotland, which I could download from the Apple app site, but I don't know if you can get it on Android. And the Royal Pharmaceutical Society are currently consulting on their polypharmacy guidance. And there are also lots of tools that you can use to look at people's medicines, and here's some of them: the Stop-Start Toolkit, the No Tears tool, and the Beers criteria. I find these unbelievably unwieldy because the Beers criteria is hundreds of drugs. So the Stop-Start Toolkit comes to hundreds of pages, well, 50 pages. The No Tears tool is perhaps the easiest in that I can get all of that on the slide. But they are worth a look, but I don't know how easy, and maybe Fran will tell us later how easy they are to use in clinical practice. Very briefly, before we get on to doing a patient, systematic review was done by NICE, and they found 28 RCTs looking at medication review. And in this space is mostly pharmacists leading the medication review. 6 of the trials were MDT and 1 was physician-led. You've seen already that a medicines review can be lots of things. So the number 1 problem is that the intervention in these trials is very heterogeneous. And I can't remember the number, but a ridiculous number of different outcomes have been used. And the majority of the trials, or nearly half of the trials, have been for single long-term conditions rather than for polypharmacy. So the systematic review basically concluded that more evidence is needed. This is probably one of the main forest plots from the review, which effectively shows where mortality is looked at as an outcome. Medicines reviews don't affect mortality. And there are some outcomes that are positive from medicines reviews, and this is a slide put together by John Minshull, who's a brilliant pharmacist who's the Deputy Director of the London Medicines Information Service. And what John did was summarise where medicines reviews helped. And you can see that generally they help in controlling single conditions like blood pressure, cholesterol, asthma, HbA1c. There are a few studies that show moderate quality evidence of things like reducing falls, reducing medicines-related problems. So there's still a big space here for us to have an impact. And I can only find 2 studies of physician-led medication reviews. Neither of them are trials. The top one is a multimorbidity clinic in Denmark, which showed that a doctor, a pharmacist, and the GP by video link could reduce the patient's medicines, improving treatment quality, patient satisfaction, and healthcare costs. And Garfinkel, the Vokodflex geriatrician from Israel, did poly-D prescribing. Now, this wasn't randomized. He managed to get the GP to stop more than 3 drugs in 69% of people, and in the other 31%, the GP ignored him. So it's not randomized. But you can see that he found that he was able to get the polypharmacy list down by over 3 drugs, producing significant improvements in health, but not in hospitalization rate or mortality. So really just a little pointer here is that when we're going to be doing this stuff, if we're going to measure it, we don't want to be looking at hospitalization and mortality. Perhaps we want to be thinking about health. So put your thinking caps on, because we're going to go through a ride through what a clinical pharmacology assessment might look like. So I have this dream that one day I'll get a letter like this that will say, "Dear clinical pharmacologist, please see this patient with polypharmacy." This is a fictitious letter from a respiratory team about Mr. Young, who's 79. He's been in hospital 6 times this year with hyponatremia, urine retention, falls, reduced mobility, respiratory failure, and confusion. And the letter usually gives us the past history. Usually, especially if it's a GP letter, it will be in chronological order, which will be printed off the record summary. And we usually get the medication list alphabetically. And in this case, the patient's on 18 different pharmacological agents and 19 different formulations, because he's on inhalers and nebulizers for his salbutamol. He's got no known allergies, luckily, because he's on pretty much everything in the BNF. And the respiratory team are concerned that his polypharmacy is precipitating his multiple hospital admissions and would be grateful for us to rationalise his medicines. So I'm now going to introduce you to something we've been developing at St George's, and very similar to what other people have been doing at Imperial and UCL. And we called it the Clinical Pharmacology Structured Assessment. And the reason we've called it the Clinical Pharmacology Structured Assessment is because of what the St George's Respiratory Questionnaire did for St George's. So at St George's, we have a respiratory questionnaire, and it's very famous worldwide. So everybody in the respiratory community has heard of St George's. So we thought if we have a clinical pharmacology assessment, then clinical pharmacology will become a household name, which will be part of our campaign to rule the world. Now, the great thing about ClinPharm is that we are very common sense people. And so the structured assessment is not rocket science. And here we have a way of sorting information so we can see the patterns, which is essential to us in looking at multiple diseases and medicines. And so very simply, we have the diagnoses by system. We'll talk about data, the polypharmacy data set in a minute, the medications, comments on the medicines, and then our recommendations. And before I go any further, I need to introduce you to Chris and James, who you'll meet over coffee. Chris is, I never quite know what to call you, but you're a sort of ST3 level trainee, and James is an F3 level trainee, but they're both fellows in clinical pharmacology at St George's. And the 3 of us have been stuck in a dark room for months, poring over the clinical practice research data link and working out how to manage virtual polypharmacy. We hope we might manage some real polypharmacy like Fran one day. So here's Mr. Young's data now sorted like that, and already I'm feeling better because I can start to see the patterns. I can start to see his atrial fibrillation and peripheral vascular disease now sorted by system, and I can start to see what drugs he's on in the cardiovascular system that might line up with those indications. I can look at his COPD and respiratory failure. He's managed with oxygen and inhalers and antibiotics. I can look at his GU disease and his GU drugs, his cognitive impairment and depression, and start to identify some potential culprits for that in his CNS drugs. And I can see what we're doing about his osteoporosis. And you can already see a few things that you can't really see an indication for, like quinine. There's no mention of cramp. So I like to be able to see the patterns. So the second thing I'd like to introduce you to is the concept of a polypharmacy data set. And if we're going to start to roll this out into primary care, there's some data we'd like to have to judge the polypharmacy, whether it's appropriate or not. And James, Chris and I have now done this for over 1,000 prescribing decisions. And we reckon if we have this data, we could pretty much make an assessment for everything that you'd have to tackle. The things that are in normal font are the must-haves, and the things that are in the italics would be nice to have. So really good to know the pulse and blood pressure, fluid balance, and it's always helpful to know the cholesterol because everyone's on statins or not. It's good to know how breathless the patient is and what their spirometry is. It's amazing how often they're on very inappropriate inhalers for their COPD. Body mass index we find helpful, renal function, electrolytes, glucose and HbA1c, and hemoglobin. And you can see as well, if we can, we like to have a few other things. Liver function can help, some indication of cognitive function. If somebody's on B12, folate or iron, it's useful to know whether they're adequately replaced. So those are some things it's useful to collect from the patient records. So how does this look for Vincent, and how does this then help us to make an assessment? So we can now look at this and say, in our polypharmacy data set, his heart rate's 62, his AF looks like well rate controlled. He's got no fluid overload. Does he really need the frusemide? He's got a postural drop. Should we be thinking he's falling? Should we be thinking about some of these drugs that lower blood pressure? He really does have severe COPD, and he really is in type 2 respiratory failure. It's compensated with a high bicarbonate. He's probably got emphysema. He's very thin. He's got some renal impairment, so we need to keep an eye on that. And he's a little bit hyponatremic and hypokalemic, again, coming back to our drugs. So the next thing that we like to check is for drug interactions and the anticholinergic burden. And I find the BNF quite good for this in the phone. So you can't seem to get this on the actual computer, but if you have it on your phone, you can type the drugs into the interaction checker. It's very quick, and you can type them all in, and then you can pick up all drug-drug interactions. It only gives you one at a time, so it only gives you alendronic acid and calcium, alendronic acid and aspirin, etc. But it does give you them all. And you can see if you use that, for Vincent's drugs, I found 21 interactions, which I don't think is that many for 18 drugs. And I've then able to I've given them a number, and I've also given them just because this is a pharmacology talk, I've given them a mechanism, pharmacodynamics or pharmacokinetics. And in this case, most of the interactions are pharmacodynamic. So aspirin and alendronic acid can increase the risk of GI irritation. Bisoprolol, frusemide, taurazocin are all contributing to his hypertension. You can see that all those CNS drugs are causing CNS depression. The risk of giving buprenorphine, which is a partial agonist, and tramadol is that you can precipitate opiate withdrawal. His frusemide, his beta agonists, his steroids can all cause hypokalemia, which could drive arrhythmias and increase the risk of arrhythmias on quinine. And the tramadol has serotonergic properties, which can combine with the metazapine to increase the risk of serotonin syndrome. So it's quite helpful to have an interaction check. And the interactions can also go on into the anticholinergic burden, and it's quite useful to pop the drugs into the calculator. If you use this one, I've given you the reference in the slide pack. If you use this one, when you type the drug name in, if it doesn't have an anticholinergic score, it doesn't come up, so it's very quick. You only need 3 letters of a drug. And in this case, in Vincent's list, he's got an anticholinergic burden of 5. So he gets 3 for trospium, which is anticholinergic. He gets 1 for metazapine and frusemide, which both have some anticholinergic effect. And he doesn't get anything for tiotropium. In fact, none of the inhalers come up with a score, probably because of limited systemic bioavailability. So Vincent's scores is 5, and that gives him a higher risk of confusion, falls, and death, suggesting that we might want to consider alternatives to some of those drugs. So now we've got the data all together, we can now start to add our comments column. And here I'm going to run out of time if I go through everything in minute detail. But here we have a few comments. So let's look at the cardiovascular comments. We've got a man on aspirin. He's got no gastroprotection. We know his hemoglobin, it's come off the bottom, but it was 115 with an MCV of 71. But also he's got AF and he's not anticoagulated. So we can start to identify what's missing. His atorvastatin, his non-HDL cholesterol is above the European guidelines of 2.6, so perhaps it's an inadequate dose. From his bisoprolol, his heart rate's well controlled, and we know it's okay in COPD. It's good this one's on a beta blocker. His frusemide, we don't really have an indication. He's not in heart failure. He's got low sodium and potassium. There's a good candidate for a deprescribing intervention. If we look at his COPD drugs, he's on antibiotics, but he's not had an exacerbation for 18 months. Maybe he doesn't need long-term prophylactic antibiotics. His oxygen could worsen his CO2 retention, and his beta agonist could be causing his cramp. And if we could do something about that, he might not need his quinine, which has gone off the bottom. His tiotropium theoretically could contribute to urinary retention, maybe, but more likely from his trospium, which is maybe for an overactive bladder. His alpha blocker, terazosin, could be contributing to postural hypotension and falls. And, of course, respiratory depression and confusion are common with all his CNS drugs. And if we look particularly at gabapentin, that has an increased risk of respiratory depression when prescribed with an opioid, and there's an MHRA warning about that. And at the bottom, we're down to his alendronic acid and quinine and calcium. Does he need them? Is it time for a treatment holiday? So we're able to make some comments. What sort of recommendations can we make as clinical pharmacologists? Well, I think we should go back to the fact that we do think drugs are good, basically. So we may need to start drugs or increase the dose to optimize efficacy, ensure disease control, and appropriate prevention. But we also like the idea of stopping some of these drugs and reducing the dose where there's no indication. If someone's having clear side effects from a drug, it's easy to stop it, because then the risk's obviously greater than the benefits. But we might also want to stop drugs to prevent future harms, like GI bleeds, example. And also to reduce the burden. The more pills the person's on, the more likely they are to have adverse drug reactions, medication errors, and not take the medicines. So reducing the burden is good, and also reduce costs. And sometimes we need more information to make a decision. We can't always do everything the first time we see the patient. We might need to see the patient. How is the symptoms controlled? Do a test, or even go back to the specialists and ask them if how long the patient really needs to be on the drug for. Stopping medicines is particularly challenging. Munir hinted on that in his talk. And I think the key thing I'd like to say is that in the BNF we have 1,603 drugs and 18,408 preparations, licensed for prescription, but we have firm evidence-based guidance for deprescribing for 4 of them. And in fact, for antipsychotics, we only have guidance for dementia and insomnia. And the 3 of those are in Canada. And when NICE looked, the only evidence they could find for deprescribing was bisphosphonates. So we don't have any evidence, hence the vacuum at the top. So we've started trying to think about classifying drugs into why you might stop them, and we've started to call this the S-bit, but we're conscious of causing irritating mnemonics overload. So the clinical pharmacology stopping by indications tool. Remember at the beginning we looked at why the different drugs had been prescribed, and if we do that as we look at the patient's medicines, not just by whether it's for atrial fibrillation or hypertension, but what's it achieving for the patient, we can then understand the risks of stopping and think about an approach in the absence of any evidence. So if we stop a short-term, or we don't give a short-term medicine, the acute illness may be prolonged. If a drug is for symptom relief, then we stop the drug, the symptoms might come back. So it's a reasonable approach to try a treatment holiday or reduce to as needed to see if the patient can manage on less or without the drug. If the medicine is a preventative medicine, if we stop it, then the person may get development or progression of the disease. So we maybe would stop if the burden exceeds the risk. If the medicine is for disease control, then, for example, heart failure, if we stop the drug, the disease will exacerbate. And perhaps the disease control drugs are more important than the prevention drugs as we get to the end of the life, because nobody wants to have their stroke from stopping their anticoagulant, or maybe some people do, but most people don't really want to have a stroke or get worsening heart failure, but they don't mind perhaps stopping their statin, which is reducing their 10-year risk of something. And then we've, of course, got prescribing cascade drugs where stopping them will increase the risk of adverse drug reactions. So an approach to stopping may be to withdraw as other treatments stop. And if we then apply that to Vincent, we can start to see what's prophylactic. I'm running out of time, so I'm just going to skip over it a little bit. What's for disease control, what's for symptom relief, and what's for prevention. And what's the prescribing cascade, which I put quinine was at the bottom. And then that allows you to then start to negotiate your recommendations. In the interest of time, I'm going to just touch on withdrawing medicines and then finally get to the patient. And when we are stopping drugs, obviously there's some things we can stop or reduce to PRN, but we should be very conscious that there are some drugs that, if we are going to stop them, need to be withdrawn slowly. My pet bugbear is when I go on the wards and they've stopped the SSRI because they thought the patient didn't need it, or they were coming to the end of their life, and then the patient gets it with serotonin withdrawal syndrome. So I think we need to be aware that there are drugs that need to be withdrawn slowly, and as clinical pharmacologists, of course, we are. Of course, steroids, but most things affecting neurotransmission. And the speed of withdrawal, of course, may also be determined by prior treatment duration. The BNF says for SSRIs 2 weeks, but if you've been on them for 20 years, it might take you 2 or 3 years to actually come off them very slowly. And where drugs need changing, we also need to consider whether there needs to be a washout between drugs to prevent interactions with adverse effects or things that are undesirable, or there shouldn't be a washout because of the risk of treatment failure. In the interest of time, the last thing I'm going to do is mention the patient. And it seems very late in the day to mention the patient. And I guess I'm doing it this way around because James, Chris, and I have been staring at the clinical practice research data link for the last few months. And we haven't had the patient there. But of course, the most important thing really is what the patient's goals and priorities are. And the nice guidance for management of multimorbidity suggests that this should be very patient-centred. So to put the patient last is the wrong thing to do. And very important to be able to discuss with the patient what the treatments are for, what their goals and values, priorities are, their approach to risk, and to agree an individualised management plan. And so clinical pharmacology shouldn't just be an academic exercise, it should be something that we do with the patients. And Vincent wants to keep out of hospital, stay in his own home, and see his granddaughter get married in 6 months, and after that he's not bothered. I had a patient who is 82, and she said to me, I don't want to be on all these drugs for my future. She said, I'm in my future. And so she stopped her tamoxifen, which was giving her hot flushes, and her statin, which she felt was giving her muscle aches, and she felt much better. And she wasn't bothered about long term. She wanted to feel as well as possible now. And so once we add all of these things together, we're then in a position to work out what we might do. And so what I've done here is stop the aspirin, switch to apixaban, increase the statin dose, stop the furosemide, stop the azithromycin, for which I didn't feel there was indication, tried without the long-acting beta agonist, tried without the trospium, treatment holiday, added in some paracetamol as a sort of opioid-sparing, probably not very effective manoeuvre, cut down the buprenorphine dose, and got rid of the calcium, the treatment holiday from the alendronic acid, and stopped the prescribing cascade quinine. And of course, medicines review is equally a longitudinal process, not just a cross-sectional process. And so some of the orange things will be addressed perhaps at the next visit. I'll perhaps just leave you with the thought of what could a complex prescribing service look like. And we all come from a secondary care model where we all see patients in clinic. So, of course, it could be a clinic. Could it be multi-professional with pharmacy, for example, and also linking into specialties? But could it also be much more radical and perhaps more in line with the NHS plan? Could we be going out to primary care? We could access the primary care records in our safe, warm hospitals, along with the secondary care records, and make our assessment. Then go out and work in the multidisciplinary meetings in the practice with the GPs and the GP clinical pharmacists, educating, supporting, finding out more about the patient. and then seeing the most complex patient to increase our reach. And so, in summary, the growing epidemic of polypharmacy presents many new challenges. We have fantastic opportunities to contribute, and doing polypharmacy, you start to get the hang of it, and then you start to get interested, and then you start to develop skills that you didn't know you had, and then you start to do research and quality improvement, and suddenly we are a specialty. We have our own ography or oscopy. It's clinical pharmacology of a multiple medicines. I think it's essential that we have good collaboration and partnership for our small specialty to have impact. And I'd just like to leave you with some of the people that have been involved with all these discussions. Hopefully you can see it's collaborative. Our St George's team, mentioned Chris and James, but we've got primary care, epidemiology, pharmacy. The ClinPharm Skills Alliance have been essential in developing this, and a whole raft of pharmacists from the Chief Pharmaceutical Officer, Keith Ridge, Richard Goodman, who's the Chief Pharmacist for London, Nina, John and Lely, who are senior pharmacists, and also very important for us to work with innovation so that we can develop these ideas and practice. So thank you.